This is part 2 of the talk about hematuria. So in the first video we talked about a big differential and at least how to initially approach a patient with hematuria, but at this point you need to decide whether you need to send your patient to a nephrologist or to a urologist for evaluation of lower urinary tract source of hematuria. So I want to go through a couple different things that I think could help at least guide your thinking. And so we won't be speaking in absolutes, but at least different risk factors or different clinical things that will help guide you into thinking what is more likely than the other. And so we'll talk about what factors make it more likely to be glomerular hematuria and need a nephrology referral, and which things make it more likely to be non-glomerular hematuria and the patient will need a urologic referral. Now, first of all, the presence of new proteinuria would be a great sign that this is glomerular in etiology. So proteinuria, remember, is seen with glomerulonephritis, and so that indicates that there's some sort of glomerular injury. And so, if I saw more than 500 milligrams per gram of creatinine protein in the urine, that would really make me think that this is coming from the glomeruli. So typically in non-glomerular hematuria, there would be no proteinuria. And so even if there was, a lot of gross hematuria with blood clots and everything, there shouldn't be this much proteinuria. At most, you may see 1+ dipstick positive for protein on the urinalysis, but that would be the most you would see. There shouldn't be that much plasma protein leaking into the urine, even from a non-glomerular source. So proteinuria should be a really helpful piece that helps you separate the two. So next, on urine microscopy, if you saw red blood cell casts, that would strongly suggest glomerular hematuria. So only glomerular hematuria would cause red blood cell cast formation, as basically glomerular bleeding will pack together these red blood cells in the kidney tubule. And so a proteinaceous sort of matrix will keep the red blood cells together as they're lost in the urine. And then on microscopy, you'll see these little, cylinders of red blood cells stuck together inside that proteinaceous matrix. So very, very specific for glomerular hematuria. Non-glomerular hematuria will not have red blood cell casts. So another feature on the urine microscopy is the shape and size of the red blood cells. So dysmorphic red blood cells. So these red blood cells are dysmorphic, or another name are acanthocytes. So you can see how they're sort of different sizes and different shapes, and they have these little blebs coming off the membrane. These are specific for glomerular hematuria, whereas non-glomerular hematuria, bleeding from some other source, would tend to show isomorphic red blood cells. So red blood cells that are indistinguishable from peripheral smear. So you can see red blood cells about the same size and shape, and they look nice and healthy. As far as diagnostic criteria, these things haven't been worked out great, but one of the numbers thrown around is if you see more than 25% of the red blood cells on a urine microscopy, if they're dysmorphic, that could be pretty specific for glomerular hematuria. One other feature to separate these two would be the presence or absence of clots in the urine. And so this would be a feature the patient will tell you when you're taking your history. So if they tell you that there's clots in the urine amidst the hematuria, it's more likely to be non-glomerular hematuria. So non-glomerular hematuria, you're more likely to lose more actual blood volume in the urine. And so that, probably causes the propensity to form blood clots. You're going to lose less total amount of blood with glomerular hematuria, but also glomeruli and tubules produce urokinase as well as tissue-derived TPA, which will actually prevent clot formation from glomerular hematuria. So just due to the low volume and also the presence of those inhibitors of clot formation, you're typically not going to see blood clots in the urine with glomerular hematuria. And finally, the last way to sort of differentiate the two is the actual color of the urine. So with non-glomerular hematuria, think about it with a very short transit time between the bleeding source and the urine coming out to be seen. The urine's more likely to be gross hematuria, more likely to be red or pink in color. Whereas from glomerular hematuria, the blood came through the glomerulus and it may get slowed down through the tubules, especially if there's, cast formation. And by the time it comes out, it's had a very long or a longer transit time. And also combined with a low urine pH, it can actually form methemoglobin, which has a darker, more smoky brown color than normal hemoglobin. And so glomerular hematuria is more likely to have sort of this red brownish color. Patients may even say they have tea-colored urine or cola-colored urine, and this is why. And so the color of the urine can be another way to differentiate the two. Okay, so now let's talk about the approach to true hematuria. Remember, every patient deserves a really good history, physical examination, and then a urinalysis and urine microscopy. So let's say we did the UA and it was positive for heme, but also on microscopy we saw more than 3 to 5 red blood cells per high power field. So that's considered diagnostic of hematuria. So let's say that we see red blood cells. What do you do next? Now, it should go without saying, if the patient has symptoms of a urinary tract infection with pyuria, so white blood cells in the urine, this patient needs urine culture and should be treated for a urinary tract infection. Perhaps that was the cause of their hematuria. What I want you to take away from this is just that, gross hematuria or cola-colored urine in the absence of symptoms of a UTI or in the absence of pyuria would not suggest that it's an actual UTI. Unfortunately, I've seen someone who was treated time and time again for UTI when it was asymptomatic gross hematuria that was actually due to some glomerular disease. So symptoms of UTI and pyuria are the clear things that are going to point you towards a UTI. Let's say your patient has unilateral flank pain and you suspect a kidney stone. Well, next step is some kind of imaging. So most people will do a CT scan of the abdomen and pelvis without contrast, as that will give you a great look at the entire lower urinary tract and identify the kidney stone. Alternatively, you could use renal ultrasound, which could be good for maybe some proximal stones. But basically, this patient needs imaging to identify likely nephrolithiasis. So next, let's consider what the urine looks like. So if there's gross hematuria, which means the urine looks clearly bloody, and the patient came in complaining of that with clots, versus gross hematuria or just microscopic hematuria, which means we only saw the red blood cells under the microscope. We didn't see it when we visually inspected the urine without clots. So what if there was gross hematuria with clots? Well, to me, that sounds pretty concerning for non-glomerular disease. So therefore, with this patient, it makes sense to just do an imaging study with a CT scan of the abdomen and pelvis with and without contrast, and then also refer to urology. One study that is very good at delineating the lower urinary tract is the CT urogram. It does require a large amount of IV contrast, and it's a very high radiation dose. But it is recommended by urologists sometimes to better delineate the fine sort of structure of the urologic tract. But this would be a good first step at the same time as you make that referral. So next, what about the patient who has gross or microscopic hematuria without any blood clots? The next question I want you to consider is, do you suspect glomerular disease? And so the first part of this video, we mentioned that, and so I want you to consider all those features. So if the patient has new proteinuria, does the patient have new onset renal insufficiency or elevated serum creatinine that's unexplained? Do they have dysmorphic red blood cells in the urine microscopy, or maybe you got lucky and there's a red blood cell cast? But think about other things like new hypertension or peripheral edema. Anything that suggests the kidney is the primary cause should make you suspect glomerular disease, and this would prompt a referral to nephrology, and also possibly the patient may need a kidney biopsy. And I did put a renal ultrasound in here just because, remember, in our workup for a patient with a newly elevated serum creatinine, we do want typically imaging of the kidney because there's a big differential for acute kidney injury that includes obstruction, and especially if the patient has hematuria and a newly elevated serum creatinine, I'd want to already have imaging coming in, because if the imaging does not show obstruction or any cystic disease or any structural abnormality, and the patient has the persistent hematuria and proteinuria and all the rest of it, I really would be more interested in glomerular disease and probably more aggressive in pushing forward with a kidney biopsy. But remember, some patients may have just isolated hematuria with no other evidence of glomerular disease, and those patients could actually be watched and not get a kidney biopsy. But I'll leave that decision to the nephrologist at that setting. So the next thing I want you to think about is, if you do not suspect glomerular disease, I want you to ask yourself the question, does your patient have risk factors for a urologic malignancy? So here are those risk factors for GU malignancies, and this is put out by the American Urologic Association. So some of those common ones you could see just being male, age above 35, and smoking history, occupational exposure, and just having gross hematuria puts you into the higher risk category compared to the patient who just have microscopic hematuria. You can see other things related to comorbidities, prior exposures, as well as a number of other things that are worth mentioning. So when you're evaluating your patient, consider these risk factors, and if they're high risk, this is the kind of patient who would need imaging and then referral to urology. So for the patient who does have risk factors for malignancy, that patient should be referred to urology. So they should get the CT of the abdomen, pelvis with and without contrast, and then the referral. One important thing urologists can do is a cystoscopy. So this is actually direct visualization of the bladder and the ureter. So highly sensitive and specific for tumors or malignancies of the bladder and lower ureters. So this is a very important piece of the workup. So now, what about the patient who has no risk factors for malignancy? Some experts may say that this patient actually should get referred to urology for a cystoscopy, but I'm going to put here that maybe they should see nephrology for a one-time referral at least. Remember, we did mention in the past that there are some diagnoses, some glomerular diseases that can present with just isolated microscopic hematuria. Among those are IgA nephropathy, thin basement membrane disease, Alport's syndrome, and maybe a mild version of MPGN. And so a nephrologist could at least think about those. And I added a question mark here on the kidney biopsy. Maybe or maybe does not need a kidney biopsy. But at least that patient would benefit from seeing a nephrologist just for sort of an opinion to decide whether they need a biopsy or not, or whether they could just be watched and seen in clinic with serial urinalyses, and probably monitoring serial urine protein to creatinine measurements. Obviously, if the patient develops proteinuria, renal insufficiency, or worsening hypertension, that would probably change decision making here. So now, just to round out the tools available to us in our workup for hematuria, obviously, hopefully I've convinced you every patient needs a urinalysis and urine microscopy. A trained individual needs to look at the urine. Remember, you can determine if there's casts, or red blood cell casts, or dysmorphic red blood cells or not. Imaging modalities, clearly this is important. So CT scans, you could also do an MRI scan of the abdomen and pelvis. And keep in mind, if a patient cannot undergo MRI, or maybe they can't undergo CT scan, maybe if it's a pregnant woman, ultrasound is another modality that can be employed. Cystoscopy, so performed by urologists, highly sensitive and specific test for bladder malignancy or tumors or other lesions. So a very important piece of this entire workup. And we've mentioned kidney biopsy a lot. So nephrologists can perform this if there's suspicion for glomerular disease. So I've added urine cytology here at the bottom. So if there's suspicion for a bladder malignancy, urine cytology, has been used in the past. Actually, it's not recommended anymore as a first-line test. So obviously you can still do it, but I'm going to cross it out because it's not sensitive, and apparently it's specific. So if you saw obviously abnormal cells that suggest a malignancy, that would be good. That would rule in disease. But in our setting, we're interested in highly sensitive tests because we want to rule out disease, perhaps. And so urine cytology is not really recommended anymore as sort of a first-line test in the workup for hematuria. So I'm going to cross it out here. It's just not very sensitive. And so I'll leave that up to you whether you want to use it or not. But these are the key pieces that you're going to use in your workup.